Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Genesis, a range of supplements we've put together to support those diagnosed with chronic kidney disease, whether you're looking to lower your creatinine levels or bump up your eGFR. We have supplements that can help support you. And I am joined again today by the amazing, talented, wonderful, intelligent, beautiful, stunning Lindsey Zirker. I have not enough verbs, acronyms. I have no idea what the correct point is here, Linz, to reintroduce Lindsey. Lindsey is a renal dietitian who works with Jessiana Seville at the renal dietitian course. No, that's not what you work at Kidney Nutritional Institute. It's because we were just talking about dialysis and I've gone sideways. Lindsey is a renal dietitian with a huge, extensive background in dialysis. She worked in the dialysis unit for a really, really long time. She's a published author. She's put out a lot of publications. She's one of the most intelligent people that I've met, and also loves reading studies and deep diving and understanding. She's one of these really rare people. So I always love getting on a call or a Zoom with you, Lindsey, because you've always been digging into things, and she is totally humble and undersells herself. So that's my job, is here to promote her. But we're moving off minerals. So if you haven't looked before, Lindsey and I did a big series on minerals, and Lindsey has been brave enough to put her hand up and tackle a series on hormones. She did that because she just wrote a huge chapter on hormones for a what is our textbook called, Lindsey? It's like the integrative nephrology for, I have no idea.
Yeah, I don't remember what it's called now. It was like in our contract, and now I don't remember. But
Yeah. It's a big
functional medicine kidney book.
Spring of Nature textbook, and Lindsey got hormones. I was glad not to get that chapter.
I don't know why.
Because you're intelligent and smart, and everybody knew you'd be the only one that would deep dive on it, and the rest of us would be like, no, no. So we're really going to test out how much information Lindsey retained from her chapter on hormones.
Oh.
Let's start. So we're going to start for A is for aldosterone. So let's start there. So first, thank you for joining me and agreeing to do this. I know hormones are a little tricky for all the reasons that we discussed before we hit record, because sometimes they just go out when you've got kidney disease, and sometimes they're part of why you've got kidney disease, and you have to decipher that. And then you have to work backwards to know whether you're treating a hormonal pathway or whether, if you just fix some basic stuff, the hormones may go back in by themselves. They're tricky little characters, and they fall in a cascade. So when one hormone is out, there's 50 million things that should be going on. So it is a bit trickier to say hormone X does this and you treat this and everything will be dandy for the bulk of hormones, right?
Yeah, you really have to remember that your body is a whole system. And the body is not wasteful. It's like, oh, this hormone can do this, and over here it does this other completely unrelated thing you never thought of. So
Exactly. So let's start, for anyone listening, what is aldosterone as a basic big level, and then we'll dive into its relationship to kidney disease. But yeah, tell me all things aldosterone.
yes, so aldosterone is a hormone that is produced in the adrenal cortex. And a lot of times, like hormones, um, we always think of them as messengers, which is true for a lot of things, but they also kind of are more encompassing than that. So a lot of times you'll hear about hormones being produced one place, but then they actually act in another place. So that's why the messenger idea comes into play, because where it acts is in the renal tubules. And the renal tubules is where the body is, where the kidneys are either reabsorbing sodium or water or potassium, or excreting it, like, or deciding to get rid of it. And so aldosterone, that is its job, is kind of controlling that. So maybe with blood pressure control, you guys have heard of the renin angiotensin aldosterone system. So aldosterone is a part of that. And I think when we talk about renin and angiotensin, we'll kind of go more in depth of what that whole system is. but aldosterone is a key hormone for blood pressure control. And its job is to recognize you don't, um, when you don't have enough blood pressure, and then it is going to help raise your blood pressure. And it does that by reabsorbing and preventing loss of sodium. And sodium and water are like friends. They always like to flow together. So if your kidneys are reabsorbing sodium, they're going to be reabsorbing water. And when they do that, it's going to bring more fluid back into your blood vessels. So it's going to help raise the blood pressure. It's going to raise the blood volume. Um, and it's also going to excrete potassium, which will help increase blood volume. So, what will stimulate um, aldosterone to be released is if someone has low blood volume. So, a lot of times, if people are dehydrated because they don't have enough fluid in their system, or if they're having more blood loss, then their body's like, we have no pressure. So it
Help.
has to go up. Um, angiotensin 2, so another hormone we'll dig into, but those have opposite impacts. And then high plasma potassium, higher potassium levels, that's going to stimulate aldosterone. And so that's kind of like the big picture of it. Aldosterone's goal is to make sure you have enough blood pressure, and it's going to do that by um, uh, it's going to tell the body, oh, sorry, didn't mean to get rid of that much sodium and fluid, bring it back. And then it's going to get rid of potassium. So that's how it does it.
And it's really interesting you say all these things, and these are all words people with CKD are going to know about, because they're like, oh, hang on a minute. I have to keep an eye on my potassium so my blood pressure doesn't get too high. I've been told I have to, sorry, sodium. I've been told I have to cut out potassium foods and I have to stay hydrated. And suddenly you're like, hang on a minute. All of this is going to have an impact and a role on aldosterone levels, or how much is aldosterone. Simply, if you're not hydrated enough, you're going to throw
Yep.
all of these sort of things out. I mean, it makes you think, doesn't it? You say all that, and I'm like, wow, if people are dehydrated, of course you're going to get an increase in aldosterone, and then you're going to have, your sodium levels go up, and then that's suddenly going to move your electrolytes around, and then you just go, wow, is dehydration just like the beginning of a whole cascade? Like, when you start to get into this, it's like, wow, the chain reaction that can go behind a hormone being out is huge. So talk to me about kidney disease specifically. I mean, I think you've covered most of it, but is there anything else specific to CKD that we should be thinking about when it comes to aldosterone on top of what you've already mentioned?
So a lot of times people who have kidney disease, um, they seem to have higher levels of aldosterone because of the upregulation of the renin-angiotensin aldosterone system. Um, And so for many people, too much aldosterone is typically the issue. And so we'll talk about things you can do for that. But I've actually had a surprising amount of people that have low aldosterone.
Mm.
And um, the first time that I found this out was by a little oopsie that happened. I had a patient who came to me. He was quite young. I think I'm trying to remember. I don't know. He was between 20 and 30. So I feel like that's really young for someone to have stage 5 kidney disease. Like
Yeah,
he didn't know he had it. He just kind of crashed and burned in the hospital and all of a sudden found out his kidneys were failing, and they didn't find out why. So he came to work with me, and we did a lot of things to kind of rebalance acid base, and we got his GFR up a little bit, but it really wasn't moving, and I didn't know if there's something I was missing, and I had been reading a little bit more about nitric oxide and how kidney disease is typically a nitric oxide deficient state. And part of the reason for that is higher aldosterone. And so I thought, well, I don't know. Like maybe this could help. It probably won't hurt. And I was like, look, I don't know a ton about this, but if you want to try it, here's some of the studies. What do you think? And he was like, okay, let's do it. Well, it wasn't a good option for him because he had low aldosterone. I didn't know this, but when you see a pattern in your patients where they have borderline to low blood pressure, and then they have borderline to low sodium, and then they have higher potassium for no good reason. Like his
Mm.
potassium was always riding like 5.3 to 5.5. And so he took that nitric oxide and his potassium went up to like 6.1 and his blood pressure went up and all kinds of stuff. And I was like, shoot. I was like, stop. I don't know what this did. I don't know what it was. Like, don't do this anymore. And I was glad that we acted out of abundance of caution. I was like, hey, we don't know what this is going to do. Like, let's just check labs like a week after you start taking this.
Oh,
And
amazing.
and so we did that. And so then I dug deeper and found, and I was like, hey, I think that you actually have low aldosterone. Let's go get that checked. And it came back like his aldosterone was at like 3.
Oh,
And so, although the reference range says 0 to 33, I don't
yeah,
know how 0 is supposed to be like a normal level.
no.
Um, but that's when I understood what aldosterone did. I was like, well, of course, that pattern makes sense because aldosterone
Mm.
raises blood pressure. It gets rid of potassium and it also reabsorbs sodium. So when we have someone with kidney disease, even stage 5, who has low blood pressure, they don't have very much sodium and their potassium is high, even though like their CO2 is controlled and like all those things that should make you suspicious about low aldosterone. Uh,
Interesting. What did you do to bring that up? Is that something that you worked on, and did it have an on-flow effect to kidney function?
so, like, that was the first time I'd encountered that, and I was like, I don't know, hormones. And so I said, go to an endocrinologist and go talk to them. And I was like, maybe there's some other tests they can do just because most of the time hormones ebb and flow. We know this. Hormones are typically not in a constant rate. There's lots of things that can impact them. So we're going to want to see like what time of day did we have it drawn? Was that the best time of day? Like that's all stuff I didn't know at the time. So I sent him to an endocrinologist to say, why don't you get that checked out? I honestly don't know what to do with you except for not give you nitric oxide. So so that's why, like, for a lot of people, nitric oxide can be a really helpful thing if they have higher aldosterone levels because it's going to cause that vasodilation.
Mhm.
And so then that can help lower the blood pressure. But it just kind of worsens the situation if they're on aldosterone, if they have low aldosterone.
Yeah, fascinating. Okay. So we know symptoms of low aldosterone. What about high aldosterone? What are sort of the symptom pictures that people, you sort of mentioned high blood pressures or anything else
So
really
it's going to
specific?
be higher blood pressure, low potassium because it's getting rid of tons of extra potassium, and higher sodium, even when they're not dehydrated.
Mm.
Um, so kind of that opposite thing. Let me look at my cheat sheet here and see if I put any other things in for symptoms and assessment on this. Because, yeah, I don't feel like, I mean, there's so many things to manage in kidney disease that, it's easy for some of these things to just kind of go to the
Yeah,
side.
exactly.
Um, but, um, oh, okay. So other things that you can kind of look for that could kind of give you an indication that maybe aldosterone is high, or maybe things that could cause it to be high, and you're like, why would this be this way? So early in the morning, that's the peak aldosterone time. If you have a low sodium diet, then your aldosterone is going to be high because it's like, we don't have enough salt to keep water anywhere in here. And so that's where having too low of sodium can cause a problem for
Mhm.
people. Also, a really high potassium diet because your body's like, too much, please, let's get rid of this. Congestive heart failure can cause high potassium or or sorry, high aldosterone, would be a factor with that. Um, and then, of course, decrease volume. A lot of times, people who have nephrotic syndrome, um, they can have higher aldosterone levels, strenuous exercise, and psychological stress. So
Mm,
that fits with like a lot of people who have kidney disease. It's going to be um, so much more likely to be commonly high. Um, but yeah, so for low, kind of some of the opposites, a really high sodium diet, um, uh, and ACE inhibitors, because that's literally what they do is they inhibit aldosterone.
yeah.
And steroids, they can also be factors that can reduce aldosterone. But definitely like other symptoms, you're gonna have higher blood pressure. So that's kind of like the main thing.
Okay. And you mentioned the test. Obviously, there's an issue with the reference range being 0 to 33. What's your sort of, where would you like to see aldosterone? And then where in that reference range are you thinking too high, too low?
So, other reference ranges that I found that I was like, okay, this makes more sense. So for men, it was 6 to 22, I think it's nanograms per deciliter. And then for
Yeah.
females, it was 5 to 30. There isn't any like special CKD range, but like most conventional type labs, there's this really limited spectrum where we have like, okay, we've got a spectrum of labs, and we have in the middle, we have the normal range, and then on the ends, we have disease.
Yeah.
And
See you later.
okay, but really, if we're looking to see like, okay, what's going on with my patient, um, ideally, hopefully sometime in the future, because all of us will start using clinical judgment and figuring things out, we should have like a more optimal range. We should have a dysfunctional range on either side, and then we have the disease range. I think the things because that sort of guidance doesn't actually exist right now. I think that the thing that needs to be done is looking at symptoms, look at additional labs, look at risk factors and other causes. And it's just kind of like a puzzle that you're going to have to put together. Um, and so, also because people's bodies are different. So I feel like the most common hormone that gets talked about is thyroid, where there's no really like perfect range for TSH levels. Everyone is probably going to feel better at a slightly different kind of range. And so that's where a lot more individualized care is really important, and having a provider who can put those labs in context and say, well, this is normal for you, or this is really abnormal for you, or this kind of explains your symptoms, or, whatever. So that's my answer for ranges. It's not really a good one, but that's all we got.
No, I would argue it is exactly how it is. Like there is no, it's like B12. That's crazy reference
Yeah.
range.
Yeah.
B12. Like in Japan, their reference range is over 700. In Australia, that's the top end, and they're like you're toxic if you're 800. And it's like, no, so in Japan it starts at 700 as being low. Like hello, like it's crazy. So
Yeah, it's so wild. So, yeah, I think there's still a lot to learn with how to assess those levels, but I do think that with hormones in general, like understanding like that we mentioned earlier, the timing is important.
mm,
Also like how long you've been sitting upright. So let's say you're like, oh yeah, timing's important. So I got it in the morning last time. I'll go get it in the morning this next time. But before you had to get up early and run errands, and this other time you slept in and you just went straight there. That is
mm,
going to make a difference in your levels. Is it going to be a significant difference? I have no idea because no one is looking at that right now. So
mm.
no. Um, but you have to be kind of consistent with testing to assess because we don't know what we don't know right now with hormones.
Such a good point and so valid. I mean, that's always my thing with potassium, right? I'm like, how tight was the tourniquet? Like, were you hydrated? Like,
Yeah.
was it really out? Like, there's so many things that can affect it. So yeah, so interesting. Okay, so let's say you've had someone, they're classically displaying symptoms of, let's say, high aldosterone, because that's going to be our more common picture in kidney disease. You've done like 4 labs, same time of day, and you're like, yes, consistently high aldosterone, but they've got kidney disease and everything else going on. Are you going in and thinking, I need to do an intervention around driving down aldosterone? Or are you thinking, I'll treat XYZ and aldosterone should come down as a side effect? How do you tackle this when it comes to supporting the person have a good outcome when it comes to aldosterone?
Yeah. So one of the things that we were talking about before we got on is that like treatments for hormones are challenging just because there are a lot of things that are going to not only impact like any kind of lab readings that you do, but they're going to just be impacted. So, I'm looking at my notes here. So, big things that impact hormone levels: stress, physical or emotional, circadian and diurnal rhythm changes. So, think, why does everyone hate time change like daylight savings? Because it super messes up your hormones.
Yeah.
Um, Macro and micronutrient deficiencies. So like higher carb versus lower carb, higher protein versus lower like fat, like all those things are going to be impacted. Um, and vitamin and mineral deficiencies, and medications that can contribute to that. Like think about like there's so many of our hormones that rely on cholesterol. And if you're on a statin, what is that doing to your hormone balance? Like people who are on statins aren't regularly getting they're not even getting any baseline hormone things so that they have anything to compare to. And I think that seems weird. Like, why don't we want to know that?
Yeah.
And the other thing is toxins. Um, so I feel like a lot of times with almost any interventions I do, I want to find the low hanging fruit.
Mm.
What is going to be the simplest change that we can make that is going to have the biggest impact for the patient? Because kidney disease is hard, life is insane, and behavior change is hard. So, what can we do to make things like the easiest? And so, um, I like to first look at what are basic opportunities for hormone balance, that we've discovered in the assessment or any type of testing. And so let's say for someone who has higher aldosterone levels, um, a lot of times it is upregulated because the RAS system is upregulated. So a lot of that upregulation, actually, when I was digging in, so much is related to inflammation. And so it's like, well, are there opportunities for targeting obvious inflammatory situations? Um, and looking at emotional stress because we all have
Fancy.
it.
Yeah.
So again, and this is something I actually found myself, I was puzzling over this weekend. I'm like, okay, so we know stress is a problem. We know it's not going away. But how do we know when we've kind of got our bodies to a point where we're more or less regulating it better, where it's
Mhm.
not a major hang up for like every issue in our body? And again, there are some tests, but they are hormone tests, cortisol tests.
There you
And so
go.
I'm like, is that really going to tell us if we've learned how to better emotionally respond to this? I don't know. So I feel like that's a question that sometimes only ourselves can answer because you'll have to probably think about what kind of things like make me lose my jazz for no reason. Do I still respond that way? Or like, what kind of things cause me anxiety? Do they still cause that? Like, you're going to have to think about all those kind of things. Maybe other people have a better answer, but I think that's something that would be really nice for us to figure out.
Mm.
Um, and I think too, with regards to emotional stress, we really burn through B vitamins when we are stressed out. And
Yeah.
so that kind of goes back to those deficiencies. So a lot of times I feel like treating hormones, many times you can come at it sideways and be effective, or at least you can kind of clear the field because, like we mentioned before, with stress, with toxin exposure, with being undernourished, it's not going to be clear if you have a genuine hormone problem, if it's just because that's a part of your kidney disease, or if there's something else going on. And so I feel like targeting those kind of three areas is something we can do. And like I mentioned before, for high aldosterone, if you're looking at it, you're going, wow, nitric oxide is checking a lot of boxes for this person, then that could be a good option for them.
Mm.
Um, but if they have low aldosterone, don't do that.
So, and that's what I wanted to ask you as well. So, say you go, okay, I'm going to address stress, inflammation, nitric oxide pathways. I'm going to do all those nice low hanging fruits, check their B vitamins are good, all those really basic things that we'd be doing anyway if we're working with someone with kidney disease. And everything else comes back to a pretty good level, but their aldosterone stays, when you're looking at the reference range, you're like, that's just not where I want it. Are you, for people out there going, well, I've done everything and aldosterone's good. Are there other diseases or drivers where you think you need further investigation into X, Y, Z? Because this outside of kidney disease could be going on and driving elevated or low aldosterone levels, and we need to just rule these things in or out.
I mean, I definitely feel like one of the things that is important to recognize for any practitioner is like, where's your strength? And even if it's within your scope, but it's not your wheelhouse, it is okay to refer out.
Well, I love that you sent your patient to an endocrinologist. Like, brilliant, right?
Yeah, because I was like, I already messed up with the nitric oxide. I can't, I don't know what to do with this anymore. So, um, so if I'm like, maybe this is just where your aldosterone is at, but let's just do our due diligence and have you go to an endocrinologist
Mm.
and see, because there can be secondary hyperaldosteronism, if you have, like, if there's some other issue going on with adrenal glands and they're just overproducing it, um, so that could be an issue. um, I don't think that primary hyperaldosteronism is super common, but you never know. So it's
No.
just like, why not get it checked out? And I think, you know, let the endocrinologist handle it, and then you can support them from a foundational standpoint of like, okay, let's just continue to make sure you're well nourished. Let's make sure we're treating any toxin exposure you had, or um, let's work on resilient mindset. I mean, that's going to clear up a lot of stuff. So,
Yeah, I think it's really important to recognize that when you specialize in kidney disease, or that's what you do, when you're a hammer, all you see is a nail, right? And so it's really important. I speak to so many practitioners who have that, and we tell our, mainstream Western medicine off for this, like an endocrinologist will see an endocrine problem, a hematologist is going to see a blood problem, a neurosurgeon will see something in the brain. And so you have to be careful that you're not hammer nailing, like that you are thinking outside the box or going, this doesn't fit in something
mm,
I would do. I need to have someone that thinks differently to me, have a look at this patient, because, and you said this before we hit record, we don't know what we don't know, right? And so I think it's a humbling thing and a good practitioner. You and I spoke about this maybe 4 or 5 times ago when we caught up, when we're laughing, we're just like, the more you read and understand, I'm like, oh my goodness, the less I know. Like it's humbling and kind of terrifying that when you came out of uni like 25 years ago, I'm like, I know how to do this. And now you're like,
oh
patients
my
are so
gosh.
complex. It's like, oh yeah, exactly. Oh my gosh. Like it could be any of these things, but it's humbling, I think, and it makes you work in a far broader way. And I think also, to your point, it is really important to get other people involved and to refer out when you need to. And, you know, I always have a team of people working on any patient that I'm with, because I'd be silly to think I've got all the answers for one person. I don't.
Yeah, we don't know. And I think for where aldosterone's concerned, like a lot of people aren't going to have that done. Like they have high blood pressure. Is it because of
Exactly.
aldosterone? Is it because of, too low of potassium in their diet, too high of sodium? Or is it because they have sleep apnea or they have lots of toxins because of where they live, and maybe an air filter is going to be the biggest thing that helps them, and somehow air filter is lowering their blood pressure now because they're not exposed to those toxins. Like
Yeah,
it
exactly.
there could be a lot of things there, and so I think that, like, I've only had a couple of patients actually go and get their aldosterone checked, but other ones where I see that same pattern, then I'm like, okay, so we need to be looking at other options. We need to really make sure that they're not having too low of sodium in their diet, which would further push up the aldosterone, but also not too much potassium. So kind of careful balance there. And then, I just look at other options that we know support healthy blood pressure. So that's like, the alkaline diet and maybe vagus nerve activation, mindfulness, whatever kind of stress reduction thing works. Or do we need to screen for sleep apnea? Like stuff like that, we can work with that. And, you know, maybe a lot of times you don't even have to test the aldosterone. You're just like, let's just like try some different options for reducing blood pressure and see what works. There's probably a couple things because let's be honest, high aldosterone is not going to be the only issue.
No, and like you're saying, primary hyperaldosteronemia, yeah, is like so rare. So it's like it's going to be part of a bigger picture. So
Yeah.
awesome. What is there anything else about aldosterone that you feel is important for our community to understand or know? We miss anything?
Um, we probably missed a lot of stuff that I don't know yet because I feel like I'm still like just really new in dealing with this, but I think that it is helpful when we're thinking like typical approaches for high blood pressure from a dietary standpoint is like, well, we've got the sodium, we've got the potassium, and we're like looking at, stress, okay? That it kind of gives us a few other things maybe to consider. And maybe it is just something endocrine wise that's really off, or maybe it's just that other lifestyle things are impacting those hormones. So, um, I keep finding that more and more. Like the answer to everything is almost always going back to those typical things we think of for a healthy lifestyle. I actually came across this Instagram post. I can't remember who did it, but they're like, these are the things social media tells us are going to re-regulate our nervous system. And it's like all these things that are good,
I
but
saw it too. I go to work.
foundationally, yeah, like it's like
Ice
Maslow's
baths.
hierarchy of needs. Yeah,
Yeah,
like those kind of things. Oh, they feel a little bit luxurious and stuff.
yeah, 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 yeah.
But yeah, if you don't have like a home, if you don't have a safe place to live, if you're struggling financially to make it from paycheck to paycheck, like no amount of red light therapy is going to fix that stress. Like those are things that need to get in place. And it kind of built on that, like the little different kind of Maslow's hierarchy of needs. And I just felt like it is really easy to get distracted by a shiny new thing because we're just like, oh, it's so like boring. I don't really want to work on that thing.
Yeah,
But these things are foundational for a reason. Like you
yeah.
know, so aldosterone, super interesting and fun, but like don't get distracted by it. Work on the basic stuff, get good sleep, work on how you handle your stress, nourish your body. If you need to figure out if you're getting exposed to toxins, do that. And then once that seems like under control, if things are still really janky, then you can start going deep nerd on stuff. I don't know. I feel
No,
like for
I
most people, that's the best approach.
Yeah, it's funny. I saw the same post, and because I do so much biohacking, and my biohacker guy's like, "What peptide are we doing now on this?" And I'm like, "Oh my goodness, you cannot out biohack crappy sleep, not allowed, too much blue light toxicity. You can't out hack like poor diet, stress levels, bad marriage. Like I'm like, you can't. Like you just
Yeah.
can't. Like don't even add the crazy stuff. Like they're the cherry on top if you want to ultimately optimize yourself and you've nailed everything else, or you're maybe a weird patient like me that's done all that other stuff and you're just trying to figure out what will move the needle, maybe. But even then it's probably hidden in, like you say, the really low stuff and something else hasn't moved in there. So I totally agree with you. We are definitely, that's the problem with things like social media and influencers and things. Again, it's when you're a hammer or you see as a nail, when you become a biohacker or any of those things. And we've got so much, and because that's what I do, my algorithm's probably set up for it. And it's just like, yeah, but if you don't have all the other stuff right, like what's the point? I mean, number one, if you don't have a home and you don't have income, like you can forget about all that stuff. You're going to be stressed. So I
Yeah.
couldn't agree with you more there, Lindsay. I think that's such a great thing to say. And I'm definitely seeing it in my kidney community of like, and I also think it's like people do, they get bored. I don't want to keep being on the alcohol and dying. And I want to get up and go to the gym. And I don't want to regulate my sleep. Give me a shortcut. Like, I'm sorry.
Yeah, I know. Well, and I mean, I have the same conversations with myself when I like look back and I'm like, what do I really feel like is the root? It's like, yeah, I got handed a bad set of genetics, but if I didn't like have such an insane dysregulated nervous system because I was a stress case for way too long, then my normal lifestyle diet and my normal lifestyle exercise, it would have been probably enough. But because my nervous
Yeah,
system was crazy, because that's how I was. And so now I'm like, okay, refocus. Don't have to do a bunch of crazy stuff. Just, you know, and so everyone's got to find their, their foundational piece. And sometimes you feel like working on different things at different times. And I do feel like that's, I did tell a patient today that I was like, I believe in the placebo effect. Um, I was like, if you feel like you are being forced into a treatment that you don't feel like is going to be helpful for you, then it is not going to be as helpful as something that clinically may be less helpful, but you really believe in it.
totally
Like,
agree.
I mean, there has to be some kind of beneficial aspect, I think, but I think it's really important for you to choose what one of my other colleagues has called your best time choice. And what is the best thing for you to work on right now? It may not be the best clinical thing for you to work on right now, but whatever is the best, thing there, that kind of helps your foundations get in place, that's the best thing to work on.
Yeah,
So,
I totally agree with all of that. And I also think, back to your point, people know their bodies very well. So if a patient comes to me and goes, I have an inkling that it might be this, but there's nothing in the testing that looks like this, but it all happened. I'm like, man, you are the expert on your body. You're the only one that lives in it 24/7. Like, I am not going to talk you out of this if your intuition is that strong around that. Like, let's just try it and see if it makes a difference. Like, no harm, no foul, right? So
and I feel like that's really empowering when patients can have providers like that,
mm,
because I feel like sometimes as a provider, it's like, I don't really think, I'm not really seeing that. But think how many times as a provider you have been wrong.
more
Like,
than I would like to admit.
yeah, and it's okay because, we're all kind of learning these things together. But I think too, it's really valuable for the patient because even if the patient doesn't know themselves that well, they are never going to learn how to know themselves well if providers don't give them autonomy to make their own choices. So I feel like too, it alleviates a lot of stress on me as a practitioner to take so much responsibility. It's like, okay, you're the captain of this ship. Based on what I see, this is what I would recommend. But if you don't feel good about certain aspects of that, let's try something different. And I feel like it's important for people to feel confident in their health journey. I feel like, especially in the last 5 years or so, people kind of forgot that people should have full autonomy of what happens to their body. And I don't know, this conversation really far away from aldosterone, but I think that that's part of figuring out hormones and other things is listening to what your body says. So
No, I think it was beautifully said and needed to be said. So thank you.
yeah.
Right. Well, if you would like after all of that, your aldosterone checked, or even if you would just like to work with a curious, I like the word curiosity because we spoke about that last time, but a curious renal dietitian who won't just make you go on a low potassium diet and cut salt out and do all those boring things, who actually will dig into what's going on, then you can head over to kidneynutritionalinstitute.org. Lindsey and the team there, Jessiana and other renal dietitians who are all very highly skilled and qualified, can work with you wherever you are in the world because of the wonders of telehealth. And if you have insurance, I think renal dietitians are even covered under that, which is wonderful. If you have any questions, if you have any questions for Lindsey or about aldosterone or anything else that we spoke about in this podcast, please put them in below. Lindsey and I will be back to what hormone do you want to do next, Lindsey? What's on the list?
Well, let's follow up with renin and angiotensin, since we kind of introduced that today, and kind of, complete the blood pressure picture.
Let's do it. So we'll be back to talk about the renin-angiotensin system. Very interesting system. I do know taurine has a massive effect on that system. So I was just down that rabbit hole just the other day. So, yeah. So make sure you hit subscribe and like. That way you'll get notified when we put up new podcasts. If you want to know more about what we do, head to www.kidneycoach.com. There is a new website being launched the end of June, mid-June, end of May, somewhere in there somewhere. So look out for that. And you'll find us on all social media platforms under the same thing. Lindsey, thank you for your time, your genius, and your curiosity. You are always greatly appreciated. I'll see you next time to talk all things renin-angiotensin. And for everyone listening, thanks for being part of our community.